Good afternoon. We will go ahead and start. I know that some people keep walking in. It's that time of the day when our colleagues from different parts of campus walk or drive over here. But in the interest of time, to make sure we have enough time for the presentation and the discussion to follow, we will begin today. My name is Elio Gunchek. I am a professor in the program in public health, and we credit this series to our faculty and students and friends of public health in our community who nominate speakers and topics for us to host. And this enriches our research, our teaching, and our service to the community. So we thank all of those who nominate speakers, and we hope those who haven't yet will consider the opportunity to bring excellent, distinguished speakers to our campus. We also thank the Office of Extension for always helping us videotape these presentations when appropriate, and we keep the archives on YouTube sometimes, but also in our open courseware website for UCLA. Today's a very special day. It seems like in recent weeks it's always been very special, but today we have a speaker who was one of the speakers in the first of this series now 5 years ago, and we're really delighted to have him back. The second reason this presentation, last Saturday I woke up, I think it's 3 o'clock in the morning, to be part of the census for the homeless that 211 Orange County coordinated with the county called the point-in-time assessment. It was a very successful census. Those who want to volunteer next time, it's every 2 years in January. I hope that you will consider that option. So today we want to talk specifically about the healthcare continuum of care for medically vulnerable homeless. The project is called STREET2HOME. There is probably no one or no group in Orange County, Southern California perhaps, that have cared more for the homeless in our community than the Illumination Foundation, founded by Paul Leon and co-founded by Paul Cho. And they built what came out of a compassionate care. We can't have such a situation in an affluent community into something enviable and copied by different organizations with the same compassion, limited resources, and a big problem. As a public health nurse with the County of Orange Healthcare Agency, Paul Leon spearheaded a unique grassroots program to bring health access and wrap-around services to the underserved homeless population in Orange County. His passion for public health and the disenfranchised communities started with his work at the Los Angeles County USC Medical Center emergency room. And he volunteered for the LA Midnight Mission. He is currently the CEO and president of the Illumination Foundation, which is a non-profit organization whose mission is to break the cycle of homelessness in our region. He's an advocate on issues of poverty, homelessness, and healthcare. He serves on many committees to pursue that mission, including the Mental Health Services Act Committee, and he's a current board member of the National Healthcare for the Homeless. He continues to shed light on these issues by mentoring and conducting classes at Cal State Long Beach, Fullerton, Biola University, Concordia, and USC School of Social Work and UCI School of Medicine. He won the Airline Leadership Award in 2014 and the prestigious PIMCO Circle of Leadership Award while leading the Illumination Foundation. Please join me to give a round of applause to Paul. Thank you. And joining him in this presentation is Paul Cho, the other Paul, but nonetheless. Paul is the CFO of the Illumination Foundation, and he's a licensed acupuncturist and a chiropractor. He spent 16 years in investment banking, working for Goldman Sachs and Merrill Lynch, and after working in New York, Tokyo, Hong Kong, Singapore, and Seoul, he retired as a managing director in 2003 to pursue a second career. He graduated from Harvard University with a Bachelor of Arts degree in economics, and he received his Doctor of Chiropractic and Master's in Acupuncture and Oriental Medicine degrees from Southern California University of Health Sciences. He also received his Healthcare Executive M.B.A. degree at UC Irvine. So welcome home, and thank you for sharing this with us. Applause for the two calls.
Thanks, Jelly. Make sure I'm turned on here. Can give it a couple seconds. Can everybody hear me? Yeah. Sure, we're on here. There we go. Now can you hear me? Well, thank you very much. I'm so glad to be back here. Paul and I both, we have roots here, as Deli had said, that we went to the M.B.A. school here, the HEC-MBA, healthcare. And it was 5 years ago, we came here and presented to a class in social services, a much smaller class, and my, how you guys have grown, and my, how we have grown. So today I just want to tell you a little bit about the Illumination Foundation, just real briefly, but more talk about the problem of homelessness, unstably housed clients, and just poverty in general as it relates to healthcare. And I think we will, when we finish, hopefully give you a little bit more insight as we have come to learn in the last 8 years of existence on some of the needs of the community. I really wish we could give you hard, concrete answers to a lot of questions, but as you know, homelessness and unstably housed societies are extremely, extremely difficult to deal with and understand just on its surface, but we're gonna try. So I'm gonna just talk to you really quick for about 15, 20 minutes to tell you about where we've been and how we've done what we've done thus far. Paul's gonna lead you into a little bit more of this incredible opportunity that we have, and hopefully UCI has. And then we're going to save time for two of our colleagues, John Kim and Aiko Tan, to answer some questions because they really are in the weeds and hitting the pavement and could really address some of your other more extensive questions. So when we begin to talk about homelessness, we're many times not understanding our population. I think that most of the people we speak to about homelessness automatically think it is the panhandler that's standing on the corner asking for money. That could not be further from the truth. We're the fastest growing population of homeless are women with children and veterans nationwide. And as you can see, these are actually pictures of our clients that we've helped in the past 7 years. So 7 years ago when we started, and even 5 years ago when we came back to talk to the public health class, we were naive to say the least. When we had first started, we thought, okay, there's individuals, and again, we were thinking drugs, alcohol, mental illness as the major causes for homelessness. And yes, this still is a part of it, but there was actually 3 pillars of areas that we saw were difficult problems, but they were gaps in services that in Orange County especially, the safety nets weren't addressing. Many of the nonprofits that work with us in Orange County, we would attend meetings with them and they would be talking about services that they would be helping with. many of them job placement, many of them mental health, some addiction. And the big elephant in the room was housing. And not much talk about housing. People did not want to address this 7, 8 years ago. We were housing all of our families and individuals at the cold weather shelter in Orange County. And in Orange County, we have no year-round shelter. We have no year-round public hospital. We have a cold weather shelter that opens up sometime in December, runs through April, and then closes. Families and individuals can only come in during the night, and they stay from 6 to about 5 in the morning. They're asked to leave. Where they go is parks, beaches, cars. So it does a really poor job of housing our homeless. We actually began with healthcare. And again, not having a public hospital in a city of our size, 3.2 million, it is just uncomprehendable. Nationwide, when we go to meetings, I went to a meeting in Chicago and spoke with some individuals from Montana. They have 2 year-round shelters, and they have over 20 year-round shelters. And obviously their population is smaller than Orange County. So the need is there, and we'll talk a little bit more about that. Income, obviously, and we're going to show you this pretty neat slide in here about how, what kind of income you would require to be able to rent a 1-bedroom apartment, and how our families and individuals fall short of that. So these are some of the services that we offer, and again, I won't go through all of them, but it's safe to say that we learned by trial and error. When we first started, we weren't quite sure on the services that individuals needed, and being so naive, we thought, oh, they probably need this. And after a little while with trial and error, the families came back to us and said, you know, we need medical care, but we really need housing, because I can't keep going to the doctor when I have no place to go home at night. So as we developed, we found out that not only were these 4 pillars what our families and individuals were asking for, these were the 4 pillars that our county was really deficit in. And so we basically understood, along with everybody else nationwide, that permanent housing was the solution. And I'm not sure how much you're all familiar with the permanent housing model, Housing First, but nationwide, many studies have been done on a Housing First models. And basically the premise is that if you house an individual or family first, they will do whatever they need to stay in that housing. We found that to be true in Orange County. When you house somebody, they stay there. 83% of the individuals that we house first, stay in that housing for over a year. LA, we're fortunate to learn from LA. LA started a program called Fuse several years ago, in which they took the 50 most vulnerable patients off the street, and we're talking really vulnerable. We're talking mental illness, alcoholic, chronic homelessness. It was so bad when they offered the 50 individuals on Skid Row housing. They went to pick them up, they signed them up, and they just basically walked up to them and said, listen, if we give you housing, would you go? And they had 50 people that said yes, they would. So they walked them over to their housing and said, here's your new house, and here's the keys, go ahead and stay there tonight. On their way over, they lost 4 people. So that kind of gives you an indication what a difficult problem this is, and starting with the most vulnerable. A year later, they found out that they eventually did get the 50. 48 of them stayed in that housing for a complete year. Many of them addressed their mental illness, their drug addiction, and so they pioneered a lot of the thought of Housing First, and they showed that it could be done. Since that time, they've gotten federal funding, and now they have over 200 individuals that they're housing, and it's growing because they're showing that it works. When we were talking about the cost of housing, as you can see, LA Orange County nationwide is one of the toughest. The shortfall is incredible. Our population, when we're talking about minimum wage, part-time or below minimum wage, it's even a more critical factor for them. And again, some of the numbers, I'll just go through briefly. I think one of the things that hits a lot of people right off guard is 1 in 6 are homeless or live in poverty in Orange County. Many of the children that we work with are unstably housed. And what's that? What does unstably housed mean? It means that they're either in motels, they're in and out of cars, in and out of beaches, they may be doubled up, tripled up, but eventually they're ending up on the street. So unstably housed, a lot of times when you're just looking at numbers, is really important to keep in mind. Orange County this year, we had McKinney-Vento numbers, their liaisons in our schools that actually count how many homeless children are there. 28,000 this year are designated as unstably housed. And you have to think about that. Orange County with our wealth, 28,000. And we'll talk a little bit more about that as we go on. Again, and when we're looking at our cost and solution, so we have the problem. We know the problem. We've identified the problem. We've identified the problem. You know, we have a homeless problem, housing works. We have a healthcare problem, access to medical care works. That's not rocket science, but what happens along the way is that we don't have enough data to really show this. And again, in New York, you could see the cost of what it takes to house an individual. We can house an individual, and a family's not much higher for $30 a day. If you start looking at the alternatives, it's pretty clear to see that we're our best bet. We're the best bet for putting a family or individual into our housing. And that doesn't even take into account the wraparound services that we do, social work, mental health, and medical. Again, I think it would be naive for me to think that we have all the answers. We have some of the answers, but let me give you an idea of how far we've come in 8 years and tell you why. 8 years ago, we were working out of motels. We were placing people in a motel, and we really didn't understand what we were doing. We just thought, okay, let's put them in a motel, connect them to services, our job is done. And as soon as we put these families, individuals into motels, we didn't anticipate the mental health, the emotional well-being, the children's progress. There were so many factors that we didn't even look at that the first 2 years, it was crisis management. We were dealing with these people on minute to minute. We're talking about sexual abuse, domestic violence, drug addiction, mental health fallout, huge, huge social problems that we were dealing with, and we were using motels. And when we were using the motels, most of the cities didn't want us in their city because of NIMBYism. They said, no, not in our city. Why don't you go back to Santa Ana or somewhere else? And the other problem is trying to get funding from county and city. Each city informed us, and the county to that extent said, you know what? We don't really have a homelessness problem in Orange County. And so we were working out of motels. We were, as fast as we could do presentations, we did them. We were introducing people on the street, moms, teachers, students, county supervisors, or city managers. Fast forward Today, this is what we have. We have 32 emergency housing units. We have 80 bridge and 50 supportive housing. We were able to convince the city to donate some property to us, and we had some funders buy some houses. And this is really important to understand because we had the best intentions. We thought we knew what we were doing. We certainly were looking at other models. But what we didn't anticipate is the headwinds that we received from local officials. And I can tell you it was a battle every day. And one of my good partners, Dr. Handler, who's a healthcare officer, do you want to just stand up for a second? Thanks. This is Dr. Handler from Orange County Healthcare. That's perfect. Just pull the arrows out the back because Dr. Handler and I, when we first started, we both worked for the county. We would walk into places and try to explain them to them about homelessness and the need. And it was all summed up by one county manager, and I can't say his name. I wish I could, but I don't want to get sued. When we walked in, he said, "Thank you for your presentation, see ya." And I knew he was not going to approve what we were trying to get done. And I asked him, I said, "Is it NIMBYism, the reason why not in my neighborhood you don't want a shelter or us working in your city?" And he stopped for a second and he thought and he said, "No." He said, "It's no, N-O-E." And I said, "No." And he said, "Not on this earth. I don't think homeless deserve to be on this earth. It's their choice, and I wish we could rid all of them." And so we knew right then that we were in for pretty much a dogfight. As we continued to identify the problems, financial literacy, because if we had housing, how are we going to get the people into housing and sustain housing? Job readiness, job training. We started a job training program, and you would think, probably like we thought, that, okay, we'll give them a resume, give them interview skills. Oh, we were so sorely mistaken. Our families and our vulnerable group we were working with were not even at the level to really answer a phone. They weren't used to speaking to an employer, and some of them had never even held down a job longer than a week or 2 weeks, and it was just temporary work. They didn't realize that, wow, I was going to be sick, I better call in. So we embarked on a 4-week attitude adjustment for our families and our students to be able to get job training. It's a job readiness. 83% of the individuals that came through our training were able to find sustainable jobs and are still working today. So it was those links and that in-depth working with our families and individual that gave us the expertise. Our children's enrichment program came about 3 years ago. And it came about because 3 years ago we were doing great work. We were working out, putting families into apartments, not quite permanent housing, but we were putting them in transitional housing. We were linking them to resources, health, everything else. And I took a trip to Minnesota and met with Dr. Matson, who works at the Mayo Clinic and has done years of research on high mobility children. I asked her and her team to come out and take a look at our program and see what we were doing. And when she came out, she said, "You guys are doing great work, but you understand you're taking a family or individual at a specific amount of time, pulling them out of that continuum, fixing them up, and throwing them back into society. Sometimes it works, sometimes it doesn't. If you really want to invoke change, if you really want to stop the cycle of homelessness, you're going to have to start with them at 0 to 5, and you're going to have to embed the community with your resources and follow them along." She said it's a costly proposition, and it's going to take you years, and it's going to take you a lot of help. You're going to have a lot of students, professionals, all pitching in. 3 years ago, we embarked on that. We have 2 sites now, and currently we have 180 students, 0 to 5, different ages. We're about to triple that in the February 1st when we open up our Santa Ana site. We're still doing outreach like we started. Part of our program is making sure you have boots on the ground and that we're connecting to individuals. We, again, learned early on, it's not necessarily what we want or what we would like our families to develop in the skills. It's pretty much what they want and how we can help them get there. Again, you can see the numbers on healthcare outreach. You can see our recuperative program. And for those of you that don't know our recuperative program, basically hospitals have an incentive to make sure that their homeless patients don't end up on the street. So they actually pay us a fee. We take care of them anywhere from 10 to 30 days and make sure they get to permanent housing. And as you can see, all this leads to permanent housing. The cost savings are incredible. We did recuperative care for about 4 years, but we were still missing that really vulnerable population that I was telling you about LA did, the LA Most 50 Vulnerable. We found out a couple years ago that in Orange County, we had that same population here. You might think that it's not like Skid Row, but it's exactly like Skid Row. Mental illness, drug addiction, chronic homelessness. We were given a grant by UniHealth to work with St. Joseph's to identify the 20 most frequent users of their ER. And when we say frequent, our first client that we had 42 visits to the ER a month. And when we asked them about it, we thought, 42 a month, there's only 31 days. I said, you mean a year? And the social worker said, no, a month. And sometimes he had been in twice a day. 42 times for one patient a month. We identify them. This is a couple of our clients that now have moved on and have successfully fought the demons, successfully been able to get their life on track and again move towards permanent housing. And of course, we support them in all different manners. But if you could have met these two before these pictures, you would have wondered how they could even manage in a hospital, much less our streets. So that's Chronic Care Plus. Now, you know, I know we went through this fast, and I know that we talked about all the different types of homeless individuals. We've hopefully identified to you just some of the area that problem, possible solution. And of course, Paul's going to talk a little bit more about how we need your help. But I don't think it ever really sinks in until you actually work with these individuals or see one of the gaps in services real life. I'm going to tell you just really briefly right now about a gentleman named Everett Carroll. Mr. Carroll called me about 6 months ago, and I had heard his name because he was a pretty famous musician in Orange County, and he had tons of friends. And then I got a referral from a recuperative from some friends. And then I got a call from somebody from a church saying that they were helping Mr. Carroll eat, or they were feeding him. So when we got the specifics on Mr. Carroll, we found out that Mr. Carroll was 580 pounds. He was bedridden, and he hadn't always been bedridden. He worked 35 years of his life. So I called Mr. Carroll and I said, maybe we can help you get a lap band, or maybe I can connect you to a doctor. And he said, well, for one, the indignity of going to a clinic where I can't sit down and everybody's looking at me is too much for me to handle. So we went out and we saw Mr. Carroll, and he was definitely about 500 pounds. And he was not able to get around, not able to exercise, but no obvious, and this is important, medical need. He really, not really hypertensive, not really diabetic, just obese. There was no one in Orange County, or even for that matter, LA County, that was gonna take Mr. Carroll in and care for him. He had been a vital part of our community. He had worked his whole life, he had given back, and now he was stuck, and there was nowhere for him to go. So Mr. Carroll was being fed by a couple elderly ladies who would bring him dinner and lunch, and I was calling, trying to get him connected to his insurance company. Finally got a hold of the physician. The physician told me flat out, we're not gonna help with housing. We'll see him medically, but we're just not gonna help you. So we were trying to figure out how to get him into our recuperative care, because we knew it was going to be a long-term care. As I was talking to Mr. Carroll, I have to tell you, he was the nicest man that I have spoken to in years. He was patient, he was kind, he was intelligent, he was a musician, which you could tell he just loved. Last Monday, Mr. Carroll died. He is one of 8 homeless people in Orange County that died in these last 2 months. Many of them alone, many of them eligible for care, and the other ones should have care. They should have had care. So I can tell you that we take this personal. I think every one of us have a right to health care. I believe every one of us, and especially our children, have a right to an education. And for God's sakes, every one of us has a right to a roof over their head. And so we're here again 5 years later asking for your help, and Paul's going to talk to you a little bit more. But I can tell you we're here much, much better armed, much, much more support, much more conviction on we're doing the right thing and we have a solution. And the last little bit of information I'll give you to show you how far we came. 6 years ago when we first started, I didn't even really realize that you needed a board for a nonprofit. And you can tell Paul's the smart one out of the group, so he's explained to me how there's rules for a nonprofit and a board. So I was asking friends and anybody who I could run into. There's a joke now that I asked my gardener and he said no because he was too busy. Fast forward now to today, we have arguably one of the best business medical boards that nationally for even a for-profit. We have Disney, we have PIMCO, Pacific Life, Wells Fargo, St. Joseph, some real heavyweights in the business and healthcare that are helping us now. And so we are really poised to take that next step, but we're going to really need a lot more people that even have a bit of the passion that we have. And with that, I'm going to let Paul tell you about where we see us going from here. Thank you.
HUD, the Housing and Urban Development, they actually have a requirement that jurisdictions that receive HUD funding have what is called a 10-year plan to end homelessness. When our foundation got started back in 2007, Orange County had actually they've been going through the motions of talking about it, and talking about it, and talking about it. It was due to the advocacy of Dr. Handler and Paul. I think they were, thorns in many ways in the sides of some of the county officials. They accelerated the program to actually put something into place. And in 2010, they formed what is called the 10-year, it's the Commission to End Homeless, the 10-year Plan to End Homelessness Commission. They've been meeting on a monthly basis since 2010 with a grand design to end homelessness by 2020. We're now entering the 5th year of that commission having come together. And unfortunately, as a government body, it's another government body, I think they've had some difficulties in trying to make things happen. An example of it, I think most of you probably have heard about the difficulties that the county has been getting in trying to set up these 200-bed shelters. A few years ago, with the Thomas Kelly, the homeless, death in Fullerton, in the city of Fullerton, people thought that they could actually get the city of Fullerton to develop a 200-bed shelter. They bought the property, they went to the city council, everyone was for it, but then the neighborhood where the shelter would be placed, they came out in force at the last minute, and even the city council that was initially for the project had to back off. Last year, Santa Ana, essentially the same thing. The county identified a project, a property where they could locate the 200-bed shelter. They pushed forward with the project, but at the city council, at the last minute, the neighborhood came out in full force against the project because they feared for the safety of the community. What this demonstrated to us is that Orange County, despite everyone acknowledges that we need a shelter because we don't have one currently. We have the winter armories in the wintertime, but we don't have a year-round shelter for the homeless. Everyone acknowledges the need, and yet no city is willing to step up because 200-bed shelter they fear is going to attract homelessness into their community. And right from the get-go, our belief was that it would be very difficult to set up a large magnet for homelessness. So we've pretty much gone off on our own direction, trying to develop our own model of continuum of care. Paul showed you some of the housing that we've developed over time, including emergency shelter, some of the bridge housing, and permanent housing. We've been very focused on trying to develop scattered housing, where we're trying to distribute the homelessness. So they're not that visible in our community. And as part of that, when we really focus on the medically vulnerable homeless, based on our experience with the recuperative care program and the chronic care program that Paul mentioned, we've come up with this plan called STREET2HOME. And this is essentially that full continuum of care where we believe that we can take a medically vulnerable homeless person directly off the streets, work with them and get them into permanent housing. And we believe that this is possible based on what we have already accomplished with our clients. This is the logic flow of the STREET2HOME model that we are in the process of developing. Essentially what we're doing is we're encountering the street homeless. I don't know how many of you have been to the Civic Center in Santa Ana. That is really a focal point of this project. We would encounter the street homeless, and we would immediately try to figure out what their needs are, particularly, and what are their medical needs, because the population that we have worked with who are chronically homeless, their medical condition is really horrendous. So once we identify the homeless at our various outreach events, what we would do is we would assess them using nationally known best practices called the vulnerability index. This is really, many cities are already using it. Orange County is just in the process of trying to develop their own vulnerability index instead of just taking what's already a gold standard. But we would be using the vulnerability index to assess them. At the same time, we would be working with the homeless by taking them through the various FQHC clinics and working with the St. Joseph Hospital system. This is really an effort to keep them out of the emergency room, which is really the most expensive place to provide them with services. We've already been working with St. Joseph Hospital on getting the cost data of the various frequent users of their emergency room. So we would rely on that. Let's see, how do I get this off? Space button, good. And then our most recent collaboration partner is CalOptima. With the ACA passage, CalOptima, because they are the medical organization that coordinates all of the Medi-Cal insurance in California, all of the homeless, in essence, have become their clients. So all of the homeless will be covered under CalOptima insurance. So we would be working with them as well to determine the eligibility of the client for the program. And this eligibility is more actually how vulnerable are they? Because what we want to do is target the most vulnerable first. And then once we start to get the most vulnerable into permanent housing, we'll go back and begin to work with those who are less vulnerable. So those who are deemed to be less vulnerable, we will connect them with a recuperative care program and try to connect them with other resources that are out there, ranging from the different shelters, the transitional housing, and the other diversion alternatives for housing that our case managers can connect them to. For those who are the most vulnerable, we would put them into a longer period of recuperative care where we would work with them, stabilize their medical condition, teach them how to live in housing. Because again, these are the most chronically homeless, so many of them have been on the streets, some of them actually for more than 10 years. And then we would begin to work with the OC Housing Authority to get them housing vouchers, which already exist, and get them into permanent housing. So our STREET2HOME project, the goals is very simple. One, we want to demonstrate that this continuum of care for the medically vulnerable population is evidence-based and it's replicable. We've already done the pilot program, and we think that it's scalable and replicable, not only in our community, but in other areas. They've already done it in Los Angeles. We actually took the learnings from Los Angeles and tweaked it. One of the problems they had, despite the success of the program up in Los Angeles, they had many different organizations involved from the initial outreach on the streets to the housing. So in the process, they were handing the homeless client off to different agencies. And what was happening is that often there were clients that were falling back through the cracks during the handoff process, or a lot of duplication of services was occurring because the need for the new agency to get up the learning curve on how to work with that particular client. Our model, we're actually with them from the street all the way into permanent housing. There's no need to hand off the client at all. We're familiar with them, they're familiar with us. And that's also a key point, because if you try to engage these most vulnerable homeless clients, it actually takes about 6 months to get them to learn to trust you. And getting over that initial hurdle is something that our case managers, they go out, they try to make initial conversation, even despite being refused to the interaction initially, they'll keep at it until they get the trust of these homeless individuals. And once actually they open up, it's surprising how our case managers really tell us that they're actually very normal. They've lived normal lives, and this is being on the street has actually created many more obstacles. But if you were to take away just some of the obstacles, they can go back to living normal lives again. We also want to develop a framework for prioritizing the most vulnerable. And as I said, in most cases, it's the medically vulnerable that will equal most vulnerable. In the Orange County 10-year plan, if you read through it, and it is on their website at ocpartnership.net, there's no discussion of medical issues at all, which really surprised us, given that the medical issues are one of the primary causes of why they cannot get off of the street. And then we also want to demonstrate a systemic collaborative approach to tackling homelessness. And I mentioned before about how handing off a client during the process does not really work as effectively. But also, I think the need to bring in different partners into the process is critical, as we've demonstrated in our project. We're in the city of Anaheim, we're working with a faith-based group called CityNet, and what they're doing is they're trying to bring out all of the churches and other faith-based organizations in the city of Anaheim to come together and to work together to tackle the issue of homelessness. And they've done some research into what the reason why the homeless cannot get off of the street. And they said that some of the surveys said that the number one reason is mental illness. The fact that they've been on the streets for so long, the severity of mental illness has just been exacerbated so that it's difficult for them to get off the street. The second reason they found was very surprising, and they said it was the churches. And the reason why is that because if you go to Skid Row, or right here in the Santa Ana Civic Center, on any day you'll find 3-4 different churches and other organizations that are there feeding, distributing clothing. What's happening is that the homeless there are actually becoming convenient for them to be there because they're getting fed, they're getting clothing. They're not finding it as urgent to try to find other solutions to get off of the streets. So what this collaborative through CityNet we're trying to do is we're trying to bring, the feedings are necessary because obviously you can't let them go hungry. However, trying to connect them with service providers such as us to make sure that it's not just one transaction with them, but it develops into a relationship that ultimately will get them off the streets instead of just feeding them one meal to allow them not to go hungry that day. And then the last goal is to help prevent Santa Ana Civic Center from becoming Orange County's Skid Row. I don't know whether any of you have been to Skid Row up in LA. But if you go up there, even during the middle of the day, it's very scary to walk. I mean, and that Skid Row is just growing. LA County's solution to tackling homelessness has been to try to put a lot of resources into bringing services and housing to Skid Row. But what it's created is essentially a huge multi-block area where I think by bringing all of the homeless together, it's just created a much amplified problem than it really should be. And we're trying to avoid that happening here in the Civic Center. Going back to that model, what we envision with this model is tackling issues throughout Orange County with the northern county homelessness, primarily in the Buena Park, Fullerton area, the central county, Santa Ana, Garden Grove, and then South County. There really is a lack of adequate services in South County area as well. So we want to essentially replicate the outreach component, working with the FQHC clinics, and then connecting them to the St. Joseph network of hospitals. St. Jude up in North County, St. Joseph Hospital in Central County, and then Mission Hospital in South County. And they all have FQHC clinics linked to them. So we would be working closely with them to get the homeless identified on the street through their healthcare system, working closely with us. Now you ask, how do we fund this process? And that's always the biggest question. The 10-year plan to end homelessness, I always think, so you have this huge design to end homelessness. Where are you going to get the funds? Because that's also, I recognize that as a missing component in the grand design. The way we see this being funded is essentially, as we've already demonstrated, there's private money out there. UniHealth gave us $400,000 to do that pilot program just for 20 individuals over a 2-year period. We think that there's additional opportunities to get private funding to do the work for the most vulnerable population. a new member to the funding equation is CalOptima. Again, with the Affordable Care Act, they are able to, they have the insurance coverage to be able to provide, pay for the services. In addition, CalOptima recently has done something very innovative, and that is at their board, they agreed to set aside $500,000 to fund the hospitals to send their clients through our recuperative care program. And this is really innovative because they are the first CMO nationwide to set aside funding to essentially pay for a housing program. Medicare or Medi-Cal does not pay for housing. HUD does, the Health and Human Services, they do not allow that at this point under the Medi-Cal coverage. Many jurisdictions are working on, after having proven that housing is health care, that by putting the medically vulnerable clients into housing, you can actually save a ton of money. They're trying to work on amendments to allow the Medi-Cal to be able to pay for housing, but they don't pay for it right now. But CalOptima, it has set aside that $500,000 to go ahead and pay for that housing. The third component is the OC Housing Authority. Under the Continuum of Care funding from HUD, every year they give us over $16 million a year. About half of that goes to OC Housing Authority for what is called shelter plus vouchers. They really haven't been utilizing those vouchers most effectively for targeting the most vulnerable population. So they're currently in the process of reviewing how they use those shelter plus vouchers. That's over $8 million a year that could be put to housing the most medically vulnerable clients. So the funding that I've talked about is funding that already exists. It's the funding that's already being spent today to help the most chronically homeless population. In addition, there's another new source of financing that is called the Social Impact Fund. This is relatively new. There has only been 2 bonds that have been issued in the United States, but many more jurisdictions are working on this. In fact, President Obama has indicated that they are going to be supporting this much more, because this is essentially a pay-for-success program. That only if you demonstrate that you can be successful will they pay for the program. And how it works is that it may not be legible from out there, but essentially when a community faces a healthcare issue, in this case it's the chronic homelessness, but the 2 bonds that they've issued is on teenage incarceration and then the low academic performance. Those are the 2 bonds that they've already issued. But those are the problems that they've identified. And then since they're being funded by the government, and the government makes it a priority to make sure that these programs move forward, they essentially work with a service provider such as Illumination Foundation, who has a solution. Our STREET2HOME for the medically vulnerable is a solution. This private-public partnership would allow in this case, an investment bank. Both of these transactions were done by Goldman Sachs, but they would step up and create a bond and find investors to buy the bond. With the proceeds of the bond, they would give the money to the service provider to go ahead and work on the project. In the case of the first one that was issued for teenage incarceration out of this, New York City, it was a 5-year project. They issued $12 million to have a service provider demonstrate that by providing them with services, they could reduce the recidivism to a certain level. And the investors who purchased the bonds would receive a market rate payout only if that service provider reached those outcomes. It's in its 3rd year right now, so we haven't seen the end results, but at this point, things are going very well. That's why they're trying to expand this Pay for Success program. So if you look at the whole scheme, at the end, it really is a win-win-win solution for everyone. The community benefits because they're trying to get funding to tackle in this case, a public health issue, but are unable to generate the funding. The government, they want to they don't have sufficient funding, or they're hesitant, or they're red tape. In this case, the problem of trying to build a 200-bed shelter. They may have the funding, but they're finding that the government themselves directly trying to handle the issue. They're running into a lot of obstacles. And then the investors. There actually are a lot of socially minded investors out there who are willing to take a lower than market rate return on their investment. But in this case, if the service provider is able to demonstrate the outcomes, they actually get market rate. So they make as much money as investing in another bond, but with that other component of being able to contribute to our community. So that's why there is rising interest even on the investor part as well. We're really excited about combining all of these different funding opportunities to try to make our Street2Home project come to fruition. But we really need the collaboration of all the partners. CalOptima, I mentioned, the healthcare agency, Dr. Handler. We're sure that he'll be able to bring all of the whole agency behind this particular project. We're working with the National Healthcare Agency for the Homeless because we want to make sure that what we're doing is something that we're able to bring the national best practices and also get them involved in measuring the outcomes. St. Joseph Health we mentioned already. And then, I think UC Irvine has an important role to play in this whole project as well. And these are the areas where we feel that UCI can really help us. One, it's the program design. We're trying to, again, bring the best practices from all over the nation. I think we could use help. We're still relatively small nonprofit here in Orange County. We could use the help of a larger organization such as UCI in doing more research to see whether there are other models out there that we could borrow from. We have no problems with plagiarism. I know you, as students you do, but we have no problems. We want to borrow and learn from other programs that have already taken place. Data collection analysis, focus on the big data is everywhere now, and it's also true with our programs. When I was going through the HEC-M.B.A program, as part of our statistics class, our group, actually we did a statistical analysis of the cold weather armory. And we looked at why they show up to the cold weather armory. Of course, that was done in Excel spreadsheet, and it's very elementary. What we're trying to do is much more than that. So I think being able to leverage off of the statistical and the analysis support from UCI would be very important to us. Honest arbiter among collaborators. There are often times when actually, if you bring multiple service providers, there may be, we may not be on the same page on how to provide services, or among different collaborators as well. And this is where UCI, I think, given its credibility in the community and the strength that it has, would be able to play that role of an arbiter as well. And then the dissemination of findings. We would be very interested in taking what we learn with the outcomes and being able to publish it in a peer-reviewed journal, because that obviously would allow it to, the whole project to get that much more credibility and be able to not only get additional funding, but be able to allow other organizations throughout the country to be able to take it and adopt it in their community. As I mentioned, while we're out there at the grassroots level trying to get things done, it really takes a whole community. It really takes UCI, where we were incubated. It would be wonderful, I think, if UCI were to be able to work more closely with what we're trying to do to try to make this project happen. And this is why we do it. These are kids who have gone through our program. They deserve our attention and our solutions to the different problems that they face. With that, I guess we'll open it up for questions.
So, any questions? Yes, ma'am.
Thank you so much for being here. This is very enlightening and a subject I'm very interested in. You mentioned that the fastest growing populations are women with children and veterans. I'm wondering what kind of collaborations you do or do not have with the local domestic violence service agencies and veterans associations and M.B.A.
Well, we work with all of the organizations you just mentioned. The difficulty with veterans in particular is our veterans are integrated into our families or clients, and we don't really know until they come into the program because they don't really self-identify until we start working with them, and then they'll say, oh, I'm a veteran. So we do work with them and we collaborate with others. I can tell you nationally that there's a big push, and that's where we're getting a lot of the emerging data, that there was such a focus on housing veterans first that one of the comments that was made by one of the National Homeless Council, they said within 3 years there should not be one homeless veteran on the street, and they're well on their way. As far as domestic abuse, it continues to be, a cyclic event because of funding. It will gain prominence because of just what had happened with the Baltimore Ravens issue, and then people will pay attention, but it'll slip away. Our answers to both those problems is the children's program, working 0 to 5, because we see so many of the applications present themselves with the children. So,
Yes. Also that Baltimore Ravens fan because he knows I'm a Ravens fan.
Yes, sir.
Yeah, I'm curious, the issue that you both talked about is the resistance of communities to accept housing of whatever type for homeless people. Is there, the resistance I imagine is because of the stigma of homeless people and the mistaken or perhaps not mistaken idea that if there's housing for homeless people, then there's going to be increased crime and drug use and more people are going to be homeless living in the street in my community. Is there data on that you can present to a community and say, well, look, there is no problem because there's a study, there's data showing that this actually is not a big issue for you?
Yeah, that's a great question. And actually, people have told us many times that, wow, you guys are doing incredible work, but you're not showing this to the public. And a good example is Stanton. You saw those properties up there. The first city that let us move into their area was Stanton. And they told Paul and I, go ahead and come on in. They gave us a property which some of the residents really objected to us coming in there. That was 2 years ago. Since that time, one of those facilities is handling 48 families a week walk-in. And when we went back to the city council for a review of the property, the residents didn't even know we were there. So they gave us some properties that we rehabbed in an area called Tina Pacific. It was a 2-block area. When we first walked in, there were gang members, there was graffiti on the walls, the crime was really high, education low. We moved our homeless families into that area, cleaned it up, and now, in actuality, crime in that 2-block area went down 22% in 1 year. That's one of our biggest gaps in our program, is that we're not really sure how to show that. We're doing the services, and that's why we're hoping for a public health point of view could help us.
Right, UCI grad students is going to help you show that.
All right, great. Because we know we're doing the work, we're seeing anecdotally and in many cases with our data that we're doing good work, but we need to be able to show it better.
And as far as the inability to build these shelters in the different cities, I think you have to remember that we're not fighting against facts, because most of the facts around the country will show that building a shelter will not add incrementally to the blight of that particular area. but you're really fighting against perception. And that is a very difficult battle to win when you bring mothers of young families, other families who are living in that area, those involved with the schools in that area. If you bring them out in force, it's very difficult to push forward with such projects.
Yeah, these are excellent ideas for research, not just demonstrating and publishing this finding about whether or not a shelter attracts these other unwanted parameters. We used to have a colleague actually in planning, policy, and design who studied this not in my backyard syndrome. But part of it is also the perception survey of Orange County residents about homelessness. I mean, awareness is one thing, acceptance is a completely different situation. And I don't think we have anyone studying that yet. Are you able to share with us the most vulnerable, in the pilot study that you did for UniHealth, the most vulnerable 23, what health issues did they face? What's a summary of their health?
Right. Aiko, do you want to go ahead and do that? Here, let me give you that. Go ahead and stand up so they can.
Up here.
I'll let you. Aiko's our director of that program, so.
Hi, everybody. I'm the executive director of healthcare at the Illumination Foundation, and I do have a Takaba alumni. The chronic care program, we have 23 clients in-house right now. About 10 to 12 of them are already in permanent support housing, so we
Sorry, just hold that back down. Yeah.
we did quite well on that. This is good. Sorry about that. The majority of them are frequent users of the St. Joseph's Hospital ER. So they have had multiple comorbidities in the past. They have drug abuse, substance abuse, they have chronic diabetes, they have CHF, which is heart problems. They also have a lot of kind of low-level infections and kind of just medical conditions that kind of all combined created this kind of system, and then they have frequent the hospital ER quite frequently. So we have our studies. One of the outcomes that we do measure is diabetes and how they take their insulins and how the blood sugars decrease under our system. They have chronic heart problems. We monitor them for that as well. So a majority of them, though, are mental challenges and substance abuse. So under the chronic care, our goal is to connect them to either the OC, Department of Mental Health, or some kind of behavioral kind of counseling that they already might have or need to be connected to. We also try to connect them to any kind of counseling in the hospital, because if that is their go-to kind of an emergency system, then they might already have history there. And with mental illness, you want to maintain that kind of consistency. So we work with the Department of Mental Health quite frequently. They go to their service providers often, and we make sure they go to the connections. A little bit is that they also have dialysis, so dialysis is a critical thing. We often take these clients to their dialysis treatment. So I would say about maybe 50% have dialysis on hand. So those are kind of the range of medical conditions that we see at chronic care, and they are extreme. So there's a reason why they frequent the hospitals. Did that answer your question?
Yeah, if you look at most of these patients, as a matter of fact, we had a general practitioner look at the patients, and he immediately said, "What ICU is this?" And I kind of looked at him and said, "They're all on the street." And he said, "Wow, if that isn't a public health nightmare, what is?" So, well, I'm sorry, one more question back there, yes.
Yeah, you mentioned earlier that there is the standard for vulnerability which you measure, and you said that Orange County is trying to develop their own. What's the thought behind that?
Well, I'll let Paul answer that, because he's been trying to battle against using an existing, because they've been doing this nationwide for 3 years. So do you want to answer that, Paul?
Well, that is also another hub mandate to come up to develop a coordinated assessment and coordinated intake solution. Otherwise, we have the danger of potentially losing our funding. LA County, they are probably several years ahead of Orange County. Obviously, they get a lot more funding, so they have a lot more funding at risk. So they have, they're already beginning to use what is called DIs for that, which is a nationally developed index that they've been using. So they really had no reason, or they just pushed forward and rolled that out. In Orange County, because I think there was a feeling that Orange County has its own particular needs, the 10-year plan and homelessness commission, after consulting an outside consultant on this project, they are moving forward with trying to develop, or essentially take the same components that will go into such an index, but try to pull it out, make it a bit more simpler for Orange County. I think that's the ultimate goal. We want to make sure that they do add the medical component into that. So that's why Illumination Foundation will be very actively involved in the discussion process of coming up with the right measures in developing this index. The county actually had an obligation to come up with that system and roll out a coordinated assessment and intake system by this year, or otherwise we may start to lose funding.
Okay, well, thank you very much again, and if you have any other questions, you can contact us and contact Deli, so thank you very much.